Special thanks to Kelly and Carlos Pellegrini, who have sponsored this joint symposium between SSAT and SAGES. Our first speaker will be Dr. Vic Milanovich from University of South Florida in Tampa, and he's going to talk about indications, outcomes, and tips for redo anti-reflux surgery.
Welcome.
Thank you. When they gave me this topic, I was so glad that they didn't pick something controversial. Okay, all right, great. All right, so again, thank you, welcome. Always a pleasure being here and talking. This is, how does this work? I'll just do that. All right. My disclosure is not relevant for this talk. These are my objectives for this talk. We're going to discuss. We're going to try to get a better understanding of why anti-reflux operations fail, pinpointing the importance of pinpointing the cause, review some of the options to address the cause. And I'm really not going to spend a lot of time on operative nuance, although that's probably the assignment. But as people know, I tend to be iconoclastic and go my own route anyway. Because the reason why is failed anti-reflux operations are much like the first line of Tolstoy's Anna Karenina, where all happy families are happy in the same way, but each unhappy family has its own unique misery. And that's how anti-reflux operations are when they fail. So basically, when you've seen one failed anti-reflux operation, you've seen one failed anti-reflux operation. So this is a statement I pounded into my residents since I can remember. I said, we only do two things in surgery. We either make people feel better, or we help them live longer, or hopefully we do both. And if we're not doing either one of these, we're not doing our job. And in the failed anti-reflux operation, we certainly haven't made people feel better, and we possibly could have shortened their lives. And that is because failed anti-reflux operations are complicated. And I love this quote by Mark Twain: "For every complicated problem, there's a simple solution, which is wrong." So you need to be prepared to handle a complicated problem with nuance and, more importantly, a fair amount of thought. So to understand why anti-reflux operations fail, we need to define what is a successful anti-reflux operation. Well, it starts with appropriate patient selection. Were the symptoms in fact due from pathologic reflux, due to an incompetent lower esophageal sphincter, and in a patient that's physiologically fit for surgery? Was the appropriate anti-reflux operation chosen, and was it executed well? As you used to tell the residents, a good operation done badly will give you bad results. And there are no acute postoperative complications, and there was resolution of the preoperative symptoms. This is the most important satisfaction driver, not only in anti-reflux surgery, but in actually most operations. Did we actually improve the patient's symptoms? Hopefully we did it with correcting their pathologic reflux and eliminating or at least reducing the amount of anti-acid medication. And also, equally importantly, we have not created any new persistent adverse symptoms, because exchanging one set of symptoms for another set of symptoms, really not a success. So, how do anti-reflux operations fail? There are, in my opinion, three basic categories. I'm not going to go over these in detail. The main ones are judgment failure. You picked the wrong patient, you decided on the wrong operation, you didn't find out that they had some other issue that could have caused a failure. Anatomic failures, which is a thing we tend to really kind of focus in on. And then physiologic failures, things related to the patient's physiology that doomed that patient to have some postoperative symptoms. So tip number one, don't skimp on the workup and make sure that the symptoms are a result of pathologic reflux. So let's talk about the first type of failure, recurrent heartburn. This is far and away the most common of the postoperative failures that I see patients for. And frequently, you need to understand that the symptoms may not be related to reflux. It was some 25 or 30 years ago that Lee Swanstrom and Jeff Peters identified that about somewhere between 25 and 30% of patients who come in with reflux symptoms after an anti-reflux operation do not have pathologic reflux. Are you dealing with functional heartburn? And for those of you that are not familiar with the Rome classification of functional GI disease, you should, because basically it'll keep you out of trouble about operating on patients that really shouldn't be getting an operation. Do they have esophageal hypersensitivity? And let me tell you, people get put on PPIs for a lot of stupid reasons. I had patients refer to me after total gastrectomies being placed on PPIs. I mean, there aren't any proton pumps left to inhibit, and yet there we are on PPIs and we're considered a failure. But there are other types of failures as well. Was the correct operation chosen? I will submit that there is no better example of personalized precision medicine than anti-reflux treatment, because there are a lot of different ways why that happens, and so there's a lot of different ways they should be approached. Was the operation executed well? Did you end up with, no. I guess, there we go. Was a wrap malposition to begin with? Did the wrap fatigue or disrupt, or did they have one of the other problems such as a slip nissen or a herniated wrap? This requires careful preoperative evaluation. So tip number 2, know exactly with what you are dealing. And in general, when plan A fails, plan B shouldn't be a repeat of plan A. So what are going to be your alternatives? Know your options and have a well-stocked toolbox. Even though there is the old aphorism of when you have a hammer, the world looks like a nail, well, what type of nail are you going to choose? You're going to choose a carpentry nail, a masonry nail, roofing nail, box nail, finishing nail. The type of nail you choose with the hammer that you have is going to determine how well the outcome is going to be. So what should be in that toolbox? Well, first off, it would be a discerning mind. Do not act reflexively. When somebody comes in with recurrent symptoms, the thing is you don't want to jump to is, we just got to redo your wrap. That is not the right answer. You need to think about what is going on here. You need to understand the medical options. Don't just allow the gastroenterologist to dictate that to you. Know which anti-acid medications may be appropriate. Some will be more appropriate than others. Is prokinetics something that would be worthwhile? Is there ineffective esophageal motility or delayed gastric emptying that prokinetics may be of help? And sometimes, particularly in the functional disorders, antidepressants can be very helpful. The tricyclic antidepressants in particular for both the patient and sometimes for yourself, I guess. Know the different types of fundoplications that you might need to use. Is esophageal lengthening procedure appropriate, or a magnetic sphincter augmentation? Although I'm not a big fan of the endoscopic options, sometimes I can foresee maybe a TIF or mucosal resection or RFA for the selected patient might be valuable. So a few fundamental technical tips that I found effective with redo operations. Most of the time, the left hepatic lobe, particularly if it's a large one, will be adhered to the anterior surface of the wrap or the stomach. Using an energy device to divide the liver from these structures more on the liver side than on the gastric side can help reduce bleeding. Then placing a hemostatic agent on the liver and then using the retractor to provide compression on the raw surface of the liver will help control bleeding and usually will stop by the end of the case. Get an idea before you restart anything what's adhered and what's not. In general, there are more frequent adhesions on the right side than on the left side, and so kind of a left to right approach can be helpful. Liberal use of intra-abdominal endoscopy, I think, is mandatory. It helps you identify structures not only through transillumination, but also being able to feel where the esophagus and the stomach is with your instruments. I start off with undoing the wrap where it's tied together, if it's a Nissen, or if it's a toupee where it's attached to the esophagus. Because that not only does that give you a handle to kind of help get around the esophagus wrap complex, but also helps you identify the GE junction with greater ease. Tend to want to mobilize the wrap from the esophagus bluntly if you can. It's usually, again, easier said than done. Check for perforations, and it should be pretty easy to do if you have your endoscope down during the case, before you start doing anything else, because this is your best time to take care of those perforations before you start putting everything back together. Be ready to adjust your plan. There is more than one time where you're in there and you're sweating bullets trying to get this all done. What are you going to do when, again, adhesions are so dense that you can't make out any of the planes? After undoing the wrap, it's macerated and dysfunctional. After you do all this dissection and you think you're patting yourself on the back, congratulating yourself, you find a big rent in the esophagus. If whether you dissect out that Hayes is so frayed that it doesn't even hold suture, or there's prosthetic mesh there that's stuck to the vena cava, or the herniated stomach is so fixed that you really can't bring it on, or you get into bad bleeding. These are things you should have a plan for ahead of time and make sure that you have the instruments available for this. Now, I don't know about, I see a lot of very famous esophageal surgeons in the room. Perhaps none of you have run into these problems, but I have. So, failure type 2 dysphagia. This is from an article we did a few years ago that's in Drugs of patients referred to us with persistent dysphagia after a Nissen fundoplication. And what we found is that most of the time there is some type of dysmotility order which probably was there preoperatively and just wasn't recognized. This is a judgment failure on the part of the operating surgeon. Now, you are going to find mechanical causes, slip Nissen, malposition wrap, herniated wrap, or other obstructive causes like the wrap being too tight in a stricture. But again, understanding that you're dealing with a fair amount of times somebody that just wrapped the patient that shouldn't have gotten a wrap is something you need to know about. So tip number 3, see tips number 1 and 2 first. There are many causes of postoperative dysphagia, and pinpointing the cause is mandatory. Then check your toolbox. You're going to have to now, after you identified the cause of dysphagia, decide what you're going to do about it. How are you going to, if you, of course, things like if it's achalasia, you're going to convert it from the Nissen to a Heller door or a Heller toupee, whatever you want to do. If there's ineffective esophageal motility, they're not responding to prokinetic like erythromycin, you may want to convert that. But again, understanding what you have ahead of time is going to then determine what's going to be your end goal to relieve the dysphagia. Again, this is from our study here where we just looked at the patients that we converted, and you can see there's a wide range of what you have to do, and you have to be really prepared for a bear because that is the situation that you're in. And don't forget functional dysphagia. Again, we talked about functional heartburn. Functional dysphagia is a real entity, part of the Rome classification of functional GI disease. And sometimes when you have that time barium swallow, which shows that everything goes down fairly easily and there is no mechanical obstruction, and showing that to a patient that, even though you might be feeling this, things go down, that is helpful. And also don't forget, it's not just the wrap, it might be the hiatus. if the hiatus was closed too tight, or particularly if it was closed with the prosthetic mesh in a keyhole fashion, these are issues that are going to, again, have to be addressed. So tip number 4, it generally doesn't hurt to start with a dilation. I favor savory dilators as opposed to balloon dilators for 2 major reasons. Reason number 1 is that a balloon dilator only provides radial force on the esophagus, whereas the savory dilator starts off with forward force, and because of the taper will eventually get to radial force. And what's also underappreciated about a savory dilator is that you are actually dilating the entire esophagus from essentially the cricopharynx all the way down to the stomach, which you don't do with a balloon dilator. Sometimes you might get lucky and this might help. Sometimes you're not, but it's generally it's a good place to start. And again, I do these myself. I don't pass this off to the gastroenterologist because I want to actually have a feel of what it's like when I pass that dilator down. So failure type 3, the recurrent hiatal hernia. And I put recurrence here in parentheses because I'm not quite sure these are all really recurrences. Obviously, they are very common, and they can be, again, real recurrences due to poor surgical technique, maybe due to poor tissue quality. There's a lot of experimental evidence showing that the tissue quality of the hiatus in patients that have hiatal hernias is not as robust as those without hiatal hernias. Or there might be tension on the repair, although that tends to be our fallback. I don't think it's true all the time. Now, this is from a study we did a few years ago looking at the anatomic configurations of these recurrences. And so what we're going to mention here is this is what we're up against. The generally positive pressure of the abdomen and the general negative pressure of the thorax leads to this pressure differential of up to 30 millimeters of mercury. That is being transmitted along the side of the esophagus in that little itty-bitty space, at least a little itty-bitty at the beginning, between the hiatus and the esophagus. And as Dr. Lydor's physics major son could tell you, stress is force over surface area. So the force here is that transdiaphragmatic pressure, and in the exposed thin area of the hiatus, particularly anterior and to the left, since you have a very little surface area that's exposed, that stress becomes higher, and that leads to the deformity of the hiatus and the occurrence of new hiatal hernias plus the recurrence of hiatal hernias that already have been repaired. So there are other things that you can't control that also can affect the risk of recurrence as well, and these are spinal column deformities, kyphosis and scoliosis primarily. And I am sure everybody has seen a lateral X-ray of a patient with scoliosis or kyphosis, and you see that flattening of the diaphragm, again exposing more of the hiatus to that transdiaphragmatic pressure, and possibly causing changes in the tensile strength of the hiatus. That is going to be a setup for another recurrence. We see here that recurrences occur nearly not quite twice as often in these patients than without. So they're going to need a little extra attention. The site of the recurrence is usually anterior and to the left. It is actually, once you take all this down, it's not that common that those sutures that were placed there in the most robust part of the hiatus, closing the hiatus, have pulled through. Usually they're still there. What has happened is that that diaphragm, or that hiatus being exposed to that transdiaphragmatic pressure has just started stretching out again. And so just simply reclosing the hiatus is setting yourself up for another recurrence, because this hiatus has already told you it's going to stretch out. And yet, what's done is that we just reclose it. So tip number 5, reduce transdiaphragmatic pressure. This is now a little bit easier with the GLP-1 agents or bariatric surgery, because that's really the only thing that we can manipulate ahead of time to reduce the risk of recurrence. Then you need to consider what you're going to do to increase the tensile strength of the tissues of the hiatus. And I have a whole separate talk about the biophysics of that, but the bottom line is that the hiatus has already caused a hernia. You know that's going to happen again, and so how you're going to increase that tensile strength. So some of the adjuncts to do this is the use of mesh. Now, I understand that's a controversial topic. We could discuss this later. But I think the important point is that we developed this mesh we call a starburst pattern. And you see here what we're doing. Oh, let's see if I can get this. What we're doing is that we're folding the mesh of this biologic mesh over the edges of that exposed hiatus in order to protect that edge from that transdiaphragmatic pressure. And that's one of the ways to do this. Now, I think one of the real advances, though, one of the innovations, and I see Dr. Wiggins-Nasri in the audience, and thank you for the photos, is this posterior rectus flap. Now, I think this is a great idea, where basically you take this fasciculized pedicle of the posterior rectus sheath, and then you create the buttress around the hiatus to increase the tensile strength with natural fascia. And I also like that it goes right up to the esophagus. So again, you're protecting that edge of the hiatus. Tip number 6, if the wrap is intact, you may not need to redo it. This is data from John Lippen's group, where, again, doing with intraoperative endoscopy, he identifies if the wrap is intact after taking all the halar hernia down and reducing it, and then he just does a cruroplasty. Again, why make it more complicated than what it is? I think this is also something that should be in your toolbox as well. Failure type 4, bloating. This is a common problem. It's a common preoperative problem. It's one of the reasons why GI docs don't refer patients for anti-reflux operations is bloating. And failure to address this issue is, again, something that is going to cause a lot of dissatisfaction. So ask about bloating preoperatively. Sometimes up to half the people that come in for anti-reflux operation will have bloating preoperatively. And there's a lot of reasons for this. Aerophagia probably being the most common. It's underestimated that if you're refluxing, what are people doing when they're refluxing? They're gulping to try to push that refluxate down. And when they do that, they swallow air. And they start to bloat. Overeating, eating too quickly, irritable bowel syndrome, constipation, small bowel bacterial overgrowth, delayed gastric emptying, all those are potential reasons why people bloat preoperatively and also postoperatively. This is from a study we did a while back looking at people with bloating, and what we did there was gave them gastric emptying scans, and if the gastric emptying scan was abnormal, we did a pyloroplasty at the time of the operation, and you see that their bloating score dropped from a level of 4 preoperatively to 1 here postoperatively, similar to the patients that weren't bloating. The ones who had normal gastric emptying scans and were bloating, and we didn't do a pyloroplasty in them, but they still had a higher level of bloating. So it may be something to consider. Now, there are very few papers that immediately changed my practice, but this paper from Watson's group in Australia did. This is their 20-year follow-up of their randomized trial of not dividing the short gastrics. And there's primarily having to do with dysphagia. But this was a line that was in their table that caught my eye, is if you look at preoperatively, the ones that had the division and ones that didn't, you have a pretty fair amount of bloating. But look at 15 to 20-year follow-up, those patients that did not have their short gastrics divided had half the amount of bloating that the patients who did have their short gastrics divided. There might be something neurologic going on here in the gastrosplenic ligament that we're not aware of, but unless I can't do a wrap, I am not dividing those short gastrics. So you're going to have patients that bloat postoperatively, and you're going to have to manage this, and you may have to do something very uncomfortable and actually talk to the patient. I spent most of my time discussing how they eat, what they eat, and how to slow down their eating. Understand some of the anti-gas formulations like simethicone and activated charcoal. I used to have a little jar of these things in my office, and people would grab a few and walk out like you get mince out of Cracker Barrel. So this is something just to be aware of. And if they have delayed gastric emptying, consider pyloroplasty or nowadays a GPOM. So in conclusion, again, complicated problem, just touched on some of the highlights. We can talk about this all day. Maybe that's your guys' plan. But what we'll know is know what you're dealing with, have a big toolbox, be ready to adjust your plan, and set your expectations. Thank you for the opportunity to talk.
So I think we'll take questions at the end, so make little notes and we'll have all the speakers up at the end for our question session. So we'll move on now from anti-reflux surgery to achalasia surgery. We're inviting Michael Ujiki up from North Shore Health System in Evanston, Illinois. And he's going to address what to do when Heller myotomy fails, pneumatic dilatation, redo Heller, or poem.
Oh, somebody took the. Oh, here it is. All right. Maybe I plugged the wrong one in. That's it. Anyway, thank you, Brent, Steve, and Ann for the opportunity. And Brent, congratulations on your presidency for SAGES. And I was asked to discuss what to do when a patient who's had a Heller myotomy fails. Pneumatic dilation, another Heller, a poem, something else. Difficult problem. These are my disclosures. I don't think will affect the talk at all. Before I get into what the options are, I think it's incredibly important that we first make sure that we understand why the patient is coming back with dysphagia, because this is probably the biggest issue that I see from both surgeons and referring physicians. A lot of people just automatically assume it's an incomplete myotomy, but there are a lot of other things that can cause dysphagia in a post-Heller patient. Incomplete myotomy certainly is one. A misconstructed fundoplication is another. Tight crural closure. How tight should we close the crural when we do a Heller myotomy? You know, if we open up the crural to do our myotomy, how tightly are you closing it? Reflux, pseudoachalasia due to reflux and strictures. Maybe a patient's developed a hiatal hernia since their Heller myotomy. Peptic strictures. Or maybe the disease has progressed and they now have a sigmoid esophagus, and that's why they're here with dysphagia. And then there's, of course, scarring that people talk about as well. But we do see about 10 to 20% of patients are going to come back. So I think it is imperative to first figure out why are they back. Now, I actually think the most important approach first is a very good history, okay, a detailed history, and we'll talk about that in a minute. I will always get an esophagram in a patient who's coming back. I tend to get a time barium esophagram, and I always will get an endoscopy as well. So before any decision is made as to what to do, these are absolutely necessary. And then I think some useful adjuncts are things like impedance splenimetry or Botox, and sometimes manometry. Of course, if you haven't done the previous manometry, you should absolutely look at it yourself. If you need to repeat it, you can. But if somebody's had hilar myotomy and a fundoplication and you're now doing a manometry, you have to be a little bit careful because a lot of times you're going to get a high IRP. Does that mean it's just the fundoplication or the crura? Like, how does that help you? Is it really an incomplete myotomy? So I think that some of these other adjuncts can help. So early dysphagia, so when I get to the history, the first thing you should ask, when did the dysphagia start? So if the hilar myotomy was remote 20 years ago and they're coming to you with just the last few months of ongoing dysphagia, that's very different. If someone's been doing great for 18 years, it's probably not an incomplete myotomy. If somebody comes with early dysphagia, it could be a poorly constructed fundoplication. It could be too tight of a crural closure as well. So those are things to think about in early dysphagia. Maybe a technical failure. Late dysphagia is more likely to be a progression or side effect of the myotomy, like a peptic stricture. Perhaps, again, the achalasia has progressed. There's a sigmoid esophagus scarring, or maybe, again, a hiatal hernia has developed. So history is incredibly important. Now, after the history, diagnostic testing. Esophagram, as we talked about, you can really visualize the lower esophageal sphincter. Is there a bird's beak appearance? Is there an anatomic defect? Is there a diverticulum? Has the myotomy blown out? Has the patient developed a hiatal hernia? These are things you absolutely have to know because it's going to affect what you're going to do. If somebody has a hiatal hernia, well, now you're going to have to go down the surgery route, like a hilar myotomy potentially, but most importantly, a hiatal hernia repair. But if those things don't exist, you can start to think about endoscopic approaches. Now, during the endoscopy, we're looking to see, is there esophagitis? Is there evidence of GERD? What does the lower esophageal sphincter look like? I do my own endoscopy. I think that's very important. Is it difficult to get the scope through the LES? Well, that probably would imply a incomplete myotomy. And then I think impedance planimetry, which is relatively new, but we have pretty vast experience with it. And I can just tell you right now, I'm very confident with the results that I get from this test. And we know that distensibility, if it's 3 or greater, that is not likely to be an incomplete myotomy. So if the distensibility is low, then that could be a few things. It could be an incomplete myotomy. It could be too tight of a crural closure if it's early. It could be, for example, it could be too tight of a wrap as well. So the impedance planimetry to me is very important. These are typical changes that you see on the left. You see a pre-myotomy, a distensibility of 0.4, but then you see kind of a normal distensibility of 3.2 on the other side. And these are the things that we'll look at when we do the endoscopy. We do it during endoscopy as well. And I actually think this is more important than manometry. Because again, if you have a distensibility over 3, as you can see here, it's very unlikely that there's an incomplete myotomy or a tight crural closure. So you're looking at something else here, maybe reflux, for example. So again, manometry could be helpful if it shows a normal IRP, because that would mean that it's not an incomplete myotomy. But a high IRP could just represent an intact fundoplication. And this is where I think Botox is underutilized and very helpful. So if I am not sure if it's an incomplete myotomy or not, I will use Botox. And if Botox brings relief of symptoms, then that says to me that a myotomy will help. Now, the problem that we have is Botox doesn't work 100% of the time. And so if Botox doesn't work, it doesn't mean that it's not an incomplete myotomy. But it can be very helpful if the patient gets a lot of relief from that. You can also consider things like a solid barium study as well. And then a 96-hour Bravo pH study is also important if you think that reflux might be why they're back. Now, those of you that read these studies, it's very important that you understand how to read them, because a patient with achalasia is going to have very different tracings. And I think this paper actually is really good. If you're somebody who does your own pH studies, you do your own Bravos, patients with achalasia that have been treated, I think this paper does a really good job of understanding the different acid profiles that are out there. So the patients trust us. So when they come in, don't let them fall. And when I saw this, it made me think of this presentation. It's very imperative that you do the correct workup and don't hurt this patient possibly a second time. If you don't do a proper workup, then it's going to be similar to what we have going on here. This is a trust fall, okay? And so that's your patient, and then that's our surgical team back there. Okay. So let's get to what the options are. So a laparoscopic redo Heller after Heller, I'm sure, as Vic said, I see a lot of experienced people in the room, so I'm sure there's something that we've all done. Absolutely feasible. I believe it's safe. If you're going to do it, you're going to do a myotomy, obviously, somewhere else, so you have to get the op report if you can. Obviously, most of us are doing our original myotomy anteriorly, so you should really do it on the side if you're not sure. But there is a perforation rate. It's not high, but there is a perforation rate. I think this is actually presented here, which is why I chose it. This was at DDW a couple years ago. This is from a group from Italy. And you can see here that they had a pretty high success rate. Some of these patients required an additional thing like a pneumatic dilation, but if you couple those things, you had over 80% success at relieving dysphagia. So redo Heller myotomy, absolutely a feasible thing to do. I'll get to what we would typically do if somebody comes back. I would say right now that a Heller myotomy, and it would be reserved for us because we can offer all of the things. We can offer POEMs, we can offer pneumatic dilations, we can offer a Heller myotomy. I'm typically going to do a Heller myotomy if I have found that somebody has a problem with the crura or the fundoplication. So if they have a hiatal hernia, then they're not going to get an endoscopic procedure. We're going to fix that hiatal hernia. If the workup has implied that maybe the crura is too tight or the fundoplication is too tight, but maybe we're not sure, the manometry shows a high IRP, the distensibility is low, we don't know if it's an incomplete myotomy or perhaps too tight of a crural closure or a wrap problem, that patient's going to go to the operating room. That patient will get a takedown, maybe a loosening of the crura, takedown of the fundoplication, and then in the operating room, we're going to remeasure with endoflip to see if the distensibility is still low despite taking all those things down. If it is still low, then they're going to get a myotomy, as you can see here on the right lateral side and the left curvature side of the esophagus, and then we're going to make sure that we do a cruroplasty and fundoplication using impedance planimetry to ensure that we're not doing it too tight. So that's one use where, again, I think impedance planimetry to me is really revolutionary and I think will ultimately become a necessary part of every foregut surgeon's practice. It'll be a tool that we'll all need because in the operating room, it can help you make decisions. So those are some of the reasons where we would do a laparoscopic approach. Now, pneumatic dilation. You can see here, again, something presented here at DDW. Last year, 1,400 patients, Heller myotomy, door fundoplication, 8.4% were deemed failures. Ultimately, about 103 underwent pneumatic dilation, 30 to 40 millimeters, no perforations. Most of the patients were followed up for about 3 years, and you can see pretty good results, 72% asymptomatic after pneumatic dilation. So I think pneumatic dilation is a reasonable thing to do as well. Again, it's an endoscopic procedure. All you're going to do is really address an incomplete myotomy with this. We use it in select circumstances, I will say, because I do think other endoscopic approaches that we'll talk about are even a little bit better. Because again, this is kind of a blind, if you will, blind tearing of the LES. Whereas POEM, and you can see here, this was a nice randomized trial that randomized people to either POEM or PD or pneumatic dilation, and POEM actually came out on top here. Now, the only thing I would caution is that they had a very low pneumatic dilation success, and they claim that one of the reasons that pneumatic dilations was unsuccessful is because most of the patients in the study chose to cross over to POEM if the first dilation failed. Now, remember, one of the downsides of pneumatic dilation is that most of the time we need to do it more than once. Most of us will do it gently to avoid perforation and kind of warn the patient you're probably going to need more than one. And in this study, those patients then crossed over to POEM. So they really only got one pneumatic dilation, which is why I think their success rate was so low. But in this case, POEM, again, was very safe, very feasible, and a good option. So I will say that if a patient comes back to us or comes to us with previous Heller myotomy and door fundoplication, And we have deemed that it is an incomplete myotomy, whether that be through the studies that we talked about or they've responded well to Botox. Our first line would be a POEM, as long as their crura are intact, they don't have a hiatal hernia. We would obviously do the myotomy at an area away from the previous, so usually it's posterior. Usually, especially a door fundoplication plays no role in getting in the way of doing a POEM. It's easy to do. As a matter of fact, Yeleni in the audience helped us write our first redo paper on POEM and jogs. And it was a low number of patients at that time, but we've had pretty good success with POEM. So that's kind of our first line treatment for these patients. Now, I'll go back to pneumatic dilation. You could get away with no general anesthetic. So if you have a patient that's really ill or elderly and can't undergo general anesthesia, you can't do a Lapeller, you can't do a POEM, you should never do a POEM under a sedation. You need that positive pressure from the ventilator. So, pneumatic dilation is a good option if you have a frail patient that can't undergo general anesthetic, that's having recurrent aspirations or something like that, and you really feel that you need to treat them, and Botox, they're gonna be around long enough, and Botox is not really effective. So pneumatic dilation has a role, we do use it, but POEM would be our first line. Okay, and a laparoscopic Heller would be used just in cases where I discussed we need to address the crura, we need to address a wrap. That's where we're going to use laparoscopic Heller, because I know that the complication rate is significantly lower for POEM compared to laparoscopic Heller myotomy. And then I just want to lastly address one other thing, and that's end-stage achalasia. This is why, again, the esophagram is absolutely necessary. There are patients where the myotomy is actually working great, but their esophagus is becoming dilated, sigmoidal, and that's why they're back, and that's why they're having dysphagia. We just saw this patient a couple days ago, actually. What happens in these cases is they develop a sump, but unlike our houses, we don't have a pump. So, that fluid and food just collects in that sump, and that's not going to get better by just doing further myotomy. That's not going to get better by doing an anti-reflux procedure. You can see here fluid collecting in that sump area, and right there. And so food is just never, and liquid is just never gonna make it down there. And so that is going to have to be addressed, or you're not going to get a relief for the patient. So we have, for the last several years now, addressed these, fortunately, non-surgically. We haven't had to do an esophagectomy now in years for these patients, but that's clearly one option. But here we're just doing endoscopic suturing of the sump, which is a very easy procedure to do. It's a very low-risk procedure. Patients go home same day, very low risk of complications. And basically what we're doing is using the principles of endoscopic sleeve gastroplasty to suture the esophagus in a straighter formation, so that there is no sump for food and liquid to collect. So POPE stands for per oral plication of the esophagus. And again, these are permanent sutures, and the advantages are an outpatient procedure, very safe procedure. It can be redone if you need to. We've had a couple patients that we've had to do it more than once, but you can see that sump is gone, and we have a very straight shot esophagus, and it works significantly well, actually. At the beginning, there was very limited data. Now that we have a few more patients, and with a little bit more follow-up data. And for we've used it in different scenarios. Achalasia, end-stage achalasia is one of them. We've also used it in neoesophagus after esophagectomy, where the gastric conduit in the chest has become deformed and it's not emptying well. I'm sure you've all experienced that. And this is another non-surgical way to approach that. Their success rate is a little bit lower for some reason, but in achalasia, it works very, very well. And I would just say that in over 90% of patients we've had success, we've had to do no esophagectomies. And if you've ever done an esophagectomy in an end-stage achalasia patient, you will understand that trying to avoid that procedure is a good idea. It's one of the most difficult procedures that you can do when it comes to, esophagectomies with a big dilated, inflamed esophagus in the chest. Dangerous operation, quite frankly. And you can see here good satisfaction in patients even going out to 2 to 3 years. So in conclusion, we do see about 20% of patients will come back with dysphagia even after a successful myotomy. And the most important diagnostic approaches are, number one, it sounds simple and stupid, but a really good detailed history to try to lead you in the direction of, is this a failed myotomy or is this something else? Imaging is mandatory and an endoscopy is mandatory. You should also be equipped with the adjunct testing options like Botox, impedance splenimetry, manometry. I think that a laparoscopic redo Heller myotomy is safe and feasible and should be first choice if there's something wrong with the crura, like we talked about. But in our hands, an endoscopic procedure like POEM would be first line because it's safer and it's easier on the patient. The recovery is less. And POEM works very well, as you could see, after a Heller myotomy as well. Pneumatic dilation is also a feasible approach. It's endoscopic, doesn't require general anesthetic, so a good option for those that can't undergo that. But the other thing you have to keep in mind is where you're at and what are you good at. I mean, if you don't offer some of these things, then you have to do what you do well. And so, you know, you have to really keep in mind what the center expertise is. And then I think that the per-oral plication of the esophagus is a new and promising option for end-stage achalasia as well. Thank you again for the opportunity.
Thank you, Mike. All right, our final speaker is Dr. Michael Awad. He's at Washington University in St. Louis, and he's going to talk to us about failure of pyloric drainage procedures in patients with gastroparesis.
All right, thank you. If we can switch back to the other computer, please. See if I can do that from here. No.
Sorry about that.
It's all Mike's fault.
Yeah, Ricky reconfigured it for the. Yeah, hold on a second.
There it is. Okay.
Here we go. Patience.
Were you not able to open it? I don't know why it won't open.
Yeah, it's not.
Well, it just won't get. It just won't open.
Yeah, no, I think we gotta. Oh, we gotta. Oh, we gotta. Think. Oh my God! Hey, which one it is? This one?
It's this one.
Okay, I gotta turn it back, but I don't know. I gotta freeze. That's a power.
Should we take questions?
Yeah.
Yeah.
While we're waiting, maybe we could ask some questions while we're waiting. If anyone doesn't have a question, I have a question for Vic. Yeah.
Yeah, went back.
So, well,
Yeah, we gotta.
Answers whatever you want.
We got three, so I don't know why.
well, I was just wondering, you didn't mention in your talk any options on when you might need to go into the chest. For patients who need redo anti-reflux surgery, I thought maybe you could comment on that.
Well, yeah, thank you for that. Well, obviously, that is something that you will have to be facile in. I didn't mention it because I had just time limitations. It's all I don't. So yeah, so there are a lot of times actually where you do have to go into the chest. I remember one case in particular where a patient had a frozen abdomen and from prior perforations, and so we actually had to repair his hiatal hernia through the chest. And as to one part, if you have a herniated stomach or even a type 4 redo hernia where you may have colon or something else in there, and you cannot bring any of those structures down from the chest, then you're going to have to do a VATS or a thoracotomy, whatever you're comfortable with in order to get that repaired. Usually when I do that, I study try to get a full upper GI series, see where most of the structures are, or you can get a CT scan if you prefer, and that will determine whether you're going to go through the right side or the left side, but typically it would go through the left side.
Did you have a comment about that, Brian?
This one?
Chest is great once in a while. We like it. We use it. Vic, my question's for you. Nice talk. You addressed a lot of things, but my question is when are you done with redo? Because if folks live long enough or around long enough, you know, we're seeing fourth time redo, fifth time redo. This past week I saw a fourth redo opinion, fifth redo. Like, when am I done? Like, how are you going to tell, how do you tell your trainees when you're done, and then what do you do? I'd love to hear your thoughts.
Yeah, that's a great question. These hiatal hernia patients, particularly the paraesophageal hiatal hernia patients, are almost like vascular patients. You only need a few of them, and you just operate on them over and over again. No, that's a great question. Usually after the third one, then we're talking about, if feasible, doing a gastrectomy. And that is the kind of the end stage anti-reflux operation, in my opinion. However, I do approach that with a great deal of caution and a lot of discussion. Because, again, that is a big operation just for symptom control, so it has to be something that there's no other way to control their symptoms.
Even if you've done that, the height of the failure point, so you're not thinking, well, if I do the gastrectomy, you fall off and we have to hold.
Yes. And, at some point you gotta say, look, I can't poke this bear anymore, otherwise I'm going to get eaten. And that's going to be a very individualized decision. And so I have told patients, no, you're not getting an operation from me, because it's not worth it. I remember one patient very specifically said, well, I want you to do something, and if I die on the operating table, it's fine. I said, well, it might be fine for you. It's not fine for me. So, sometimes you have to stop.
And what about just permanent closure of the hiatus, if we rupture the esophagus,
With what, like a colon interposition? Yeah, I have to tell you, I am very reluctant to do colon interpositions for benign disease, because that colon, like an end-stage achalasia, tends to get big and floppy and acts like an achalasia patient. So I try to avoid that. I've done it in the past. I don't like it.
Renato Salvador, University of Padua. I really enjoyed both the lecture. I have one question for all of you. Vic, do you use any nasogastric tube after, when you are done? I mean, I'm thinking about the gastroparesis after this really difficult procedure, or any drainage close to the hiatus or close to the, or in the hole to the chest, because sometimes we have some bad seroma after the procedure. So some tips from you for this. And for you, what are you thinking about the pull-down technique in the end-stage achalasia? Because we just saw the Pope, but probably from the surgical point of view, what are you thinking about the pull-down technique?
Well, I'll answer the NG tubes. I used NG tubes routinely, and I would admit that I'm old-fashioned and a bit of a dinosaur. Maybe not as much as Steve here. He's more of a dinosaur than I am. But I use them routinely.
When do you feed the food to your patient?
I'm sorry?
When do you make your patient eat? Couple days, a week?
Yeah, no, basically, my routine was we have an esophagram or an upper GI the next day. If everything looks good, pull the NG tube, start them on a liquid diet, and advance them to a soft diet. And again, a lot of counseling as to what to eat, what not to eat, how to eat. Put your fork down in between bites, chew your food well, just like everything your mother used to tell you. So.
Yeah, I guess before I answer that question, I want to just clarify what you mean. Are you talking about dissecting out the distal esophagus and bringing it down? Is that what you're saying? Boy, that sounds so great and easy. It is. Have you done it before? It's incredibly hard and difficult to do. And as a matter of fact, I'm not really sure that you ever really truly get the majority of the esophagus down. So I would say that that's not a great procedure. I'm not sure how the others feel, but it sounds like it would be easy. It's not. These end-stage achalasia esophagus typically are very inflamed, very dilated. You don't have a lot of room up there, and it does not move and come down very easily. So I think that's a procedure that if you're at that point, you're probably looking at just doing an esophagectomy anyway, because it's probably not going to work.
We're just gonna let Mike finish his talk and then do our questions at the end. Thanks.
All right. Well, thank you. I think I'm going to change my talk title to When Your Computer Fails and what to do. It reminded me not to follow Dr. Ujiki anymore for several reasons. It was a great talk from both presenters. And thank you to all the moderators for the invitation to present today and to SSAT. So I've been asked to talk about what to do in pyloric drainage procedures fail in patients with gastroparesis. My disclosures are as following. We have a number of research grants for our simulation center from a variety of industry partners. So just a quick review on gastroparesis. So and I think this is really important as part of our definition as well too, which is just to remember gastroparesis is a syndrome defined by delayed gastric emptying, and this is critical in the absence of mechanical obstruction. And the cardinal symptoms are nausea, vomiting, early satiety, bloating, and abdominal pain. Those are kind of the 5 key cardinal symptoms, but a number of these patients also do have other things such as heartburn or GERD, can have very labile glycemic levels, lack of appetite, and also changes in their weight, which we'll all come back to here in a little bit. The etiologies of gastroparesis are myriad. We think about diabetic and idiopathic as our major 2 buckets, but there's also post-surgical gastroparesis and a whole host of things we're probably doing that cause gastroparesis with a number of the medications, opioids, THC-containing products, and especially nowadays, GLP-1 receptor agonists are a significant component and something we actively screen for as well too. The pathophysiology behind gastric emptying is complex, and a lot more people expert in this than I can speak much more cogently on this, but a combination of things that include fundic relaxation, the antrum motility or lack thereof, the gastric rhythm or pacemaker effect or dysrhythmias of that, as well as the pylorus itself, pyloric spasms being one component of it. So now we'll turn to the drainage procedures themselves. And one caveat, we'll come back to, I just wanted to mention, in our center, we generally start with gastric electrical stimulation as our first-line therapy for medically refractory gastroparesis. And this practice has actually changed quite a bit over my practice. I used to do a lot more pylorus relaxing procedures, first lap pyloroplasty, and then when we got into POEMs, we did more J-POEMs, but now we're gravitated towards gastric electrical stimulation as our first-line therapy. We'll expand on that and come back to that more. I do want to just augment a comment that was made by both of the previous speakers, which is key to have a lot of tools in the toolbox and not to have just kind of a one-trick pony or one thing that you can offer your patients. So the pyloric drainage procedures generally come in the laparoscopic pyloroplasty. This is the eponym is the Heineke-Michelitz, where a longitudinal incision is made across the pylorus, and then it was closed transversely with the target of widening of the pyloric channel. And then again, more recently, the so-called G-POEM, or sometimes the peroral pyloromyotomy, which is the endoscopic cutting of the pylorus muscle. Unlike pyloroplasty, this is not a full thickness incision. So just as a nomenclature, this is a myotomy, not a true pyloroplasty. But the rationale for both is to try to treat pyloric dysfunction or pylorospasm or hypertonicity that may be a component of delayed gastric emptying in a subset of patients. And again, I think the operative word there is subset, and trying to reduce the resistance to gastric outflow. The success rate has been reported throughout the literature in many, many studies. It's variable, but anywhere from 40 to 60% clinical improvement in GCSI scores, and we'll come back to that patient-reported outcome measure in a little bit. But definitely has been shown to create objective improvement in gastric emptying times as measured by nuclear scintigraphy. And between the two, fairly similar outcomes between the laparoscopic and endoscopic approaches, again, depending on what paper that you'll see. Now, why do these fail? And unfortunately, there is a significant proportion of patients that experience either primary failure, where they have no initial response, or secondary failure, where their symptoms recur. These rates of failure, again, are quite variable, but in laparoscopic pyloroplasty have been reported as many of 30% of patients that need subsequent interventions, like gastric electrical stimulation, or in G-POEMs, where the recurrence rates can be 13% per year or higher. Again, the challenge is managing these patients can be difficult, and they often have severe symptoms, they have nutritional issues, and as many of the previous speakers mentioned, requires a really thoughtful, structured, and multidisciplinary approach. The part of the problem is how we define failure, and the issue is there's no single standard definition of what is considered a failure. One component of that is, again, patient-reported outcome measures. This is the GCSI, or Gastroparesis Cardinal Symptom Index. It is 3 kind of subscales of nausea, vomiting, fullness and early satiety, and bloating. And you can get scores on 0 to 5 in each of those subscales. So symptomatic failure has sometimes been described as lack of improvement in the GCSI scores. Again, there's been different ways to try to describe this with different absolute point increases or percent change or lack thereof. Persistent severe symptoms have sometimes been described as GCSI greater than or equal to 3 in each of the subscales. But again, patient-reported lack of improvement is the main symptom. The other way that people have tried to describe failures is objectively with gastric emptying studies. This is, again, nuclear scintigraphy. And we'll talk a little bit more about this, and I think some tips on how this is done. But some people have looked at lack of improvement in gastric emptying times as a way to measure failure. I think the bottom line is this is, again, difficult because symptom severity doesn't correlate very well with the degree of gastric emptying or its delay. And I think really the best approach in how we define failures is a combination of all of the above, the GCSI, the gastric emptying times, but most importantly, again, patient-reported symptoms and their quality of life. People have tried to look at what patterns predict failure. And again, you can kind of look at these as primary versus secondary. Primary non-responders are thought to be, again, early, no benefit soon after the procedure within weeks to months. And secondary failure is where there's an initial improvement, but then symptoms recur. Different things have been reported in the literature. Again, this is fairly variable and inconsistent. For pyloroplasty in particular, factors such as younger age or a higher baseline GCSI have been predictors of failure. For G-POEMs, the longer the gastroparesis has presented prior to treatment, higher BMI patients, psychiatric medication use, female gender, absence of nausea and vomiting as a primary symptom, are all factors that have been associated with poor outcomes from a G-POEM. So again, why do these procedures fail? I think you can kind of describe, and again, I like Dr. Vilanovich's kind of way of categorizing this, and we can think of this in a fairly similar way. One is technical factors, and Dr. Ujiki also talked about this from the poem standpoint. That is incomplete myotomy, perhaps fibrosis that occurs soon after the procedure, or that the pylorus or pyloric malfunction is actually really not the main driver of that patient's symptoms. And we'll talk a lot more about that piece here shortly. Another bucket of why these may fail is the understanding the underlying pathophysiology. Just that gastroparesis, as we talked about, is much more than just the pylorus. In fact, unlike achalasia, where the LES is an inherent part of the symptomatology, in most patients with gastroparesis, the pylorus is normally functioning. It's more of the gastric body motility and other factors. Again, other things like antral hypomotility, the fundic accommodation, a lot of times the anatomy. Some of these patients have very severe anatomical changes of their stomach where they have a very J-shaped stomach, almost a pelvic stomach, that can make emptying very difficult. And again, no amount of pylorus relaxation is going to help those patients. And again, patient factors and selection. The duration prior to presenting for therapy, high BMI, opioid use is a huge factor, and again, poor glycemic control. And then other things as well. You know, there's a whole constellation of overlapping GI symptomatology, such as functional dyspepsia, IBS, small intestinal bacterial overgrowth, that can also complicate why these patients continue to have symptoms. So now the question is what to do when these drainage procedures fail. And I think, again, you know, it comes back to basics and starting all over, starting at the beginning. So we'll kind of talk about an algorithm there. This is a really nice algorithm that was published a few years ago through the ACG that I think is just a great overall paradigm, not just for failure of pylorus relaxing procedures, but also for gastroparesis as a whole, starting again, as Dr. Ujiki said, with a very thorough history as to why this is going on, what they've tried so far, how long this has been going on for, appropriate diagnostic methodology, dietary and behavioral modifications, medical management, before we attempt surgical procedures. Now, coming back specifically to a pylorus relaxing failure, I'll kind of propose the following algorithm and open for discussion. So again, as Mike said, starting with the complete history is key. After your pylorus relaxing procedure, how did you feel? Did you notice improvement, or maybe there was no improvement? When did the symptoms come back? What is causing your symptoms? What have you tried so far to help, and what doesn't help? All of the usual things. Have there been any interval changes? Particularly in diabetic gastroparesis, we know that poor glycemic control can have a significant impact on their symptomatology. So what is their A1C? Are they plugged in with an endocrinologist and so forth? So then again, after that is diagnostic evaluation. We have EGD is a core part of this as it is for achalasia, as well as gastric emptying studies. Gastric emptying studies, just make a note on one thing that I think is very, very important is that these are 4-hour studies. Sometimes we'll get patients sent to us with 2-hour gastric emptying studies that are abnormal. But in fact, if you repeat it, you'll find that they catch up, and at 4 hours, they have normal emptying. And in fact, the ACG, AGA guidelines, and actually the new AGA guidelines on gastroparesis all suggest a solid phase 4-hour gastric emptying study. That's very, very important. One thing that we do is for 3 weeks prior to this study, patients have to be off of all opioids, all THC, and now GLP-1 receptor agonists. And this is a hard thing to do, especially in the opioid category, because a lot of these patients have chronic pain, a lot of them are on opioids, but we actually engage our chronic pain management service as part of our gastroparesis team to try to find some non-opioid analgesics to get these patients off, at least for the test. Because you will find some of these patients, when they stop their opioids, will actually have normal gastric emptying and actually never need a surgical procedure. So again, very, very important. Understandably, this test is not perfect. In fact, if you repeat a gastric emptying study in the same patient, there's about a 30% chance you'll find a different result when repeated in the same patient with that test. There are other tests that are in research and development, but for now, this is one of the relatively good tests that we have and also required by insurance for a lot of these procedures to be approved. So if you do these tests, your upper endoscopy and your gastric emptying in a patient that failed a pylorus relaxing procedure, and you find the gastric emptying times are normal, then perhaps they may be functional or have functional dyspepsia, in which case we will obviously not offer them surgery at this point, cognitive behavioral therapy, medications, perhaps a psychiatry referral. Of a side note, and we can discuss this perhaps if the time allows, there is some interest in whether surgical therapies are appropriate for this cohort of patients, but for now, that's not certainly standard of care. If the gastric emptying times are delayed, then again, it's very important to know what the pylorus is doing. And again, by upper endoscopy or contrast studies like esophagram, if you find that the pylorus itself is now strictured again or narrowed, that takes us down a certain path. These are patients in whom a repeat pylorus relaxing procedure might be appropriate, such as a repeat GPOM or pyloroplasty. There is limited data for redo GPOM in gastroparesis. There's some small series that suggest a potential benefit, but risks for reoperative therapy may be slightly higher in these patients, although in general, in high experienced centers can be done safely. If the pylorus is normal, then we kind of go down a different path. Again, we try first with conservative management. At our center, we really have now developed a comprehensive multidisciplinary team that involves gastroenterology, a dietitian referral, behavioral management, sometimes with a psychologist, and also endocrine if they have diabetic gastroparesis. And we also, taking a page out of the bariatric book, we have them in 6 months of monitored medical management. And just a 1-week trial of Reglan is not considered adequate medical management. So they have to have done at least 2 prokinetics and at least 2 antiemetics. They have to have stopped all opioids, again, THC, GLP-1 receptor agonists, and to be nicotine-free. So there's a lot of very intensive medical management that these patients undergo. If at 6 months they're still considered refractory, then we think about surgical therapy. We'll talk about 3 options, although the one that I alluded to was gastric electrical stimulation. And as I mentioned, in our center for patients with medically refractory gastroparesis, this is our first-line therapy. Just a note, for those less familiar with this, gastric electrical stimulation involves the placement of 2 leads, 10 centimeters proximal to the pylorus, perpendicular to the axis of the stomach. The leads go into the muscularis layer of the stomach wall. They are attached to an implantable programmable generator that goes in a subcutaneous pocket underneath the skin. The procedures themselves take about an hour to do, if that. We kind of measure with a suture a spot about 10 centimeters proximal to the pylorus. Usually you can tell from the outside, but you can do endoscopy if needed to help identify the pylorus location. Those are the leads. There's a Keith needle attached to a proline that you use to tunnel the lead in that muscularis layer. And again, that's perpendicular to the long axis of the stomach. And this has been kind of mapped out in some of the early studies of gastric electrical stimulation. The leads, after they're placed, we actually do intraoperative endoscopy to confirm that they haven't gone through the gastric mucosa, and we do attach it to the generator and check the impedance just to make sure that the resistance or impedance is appropriate. So there are, again, 2 leads. They're placed about 1 centimeter apart from each other, perpendicular to the axis of the stomach. Some important considerations when we talk to these patients is that this is not an instant fix. That it does take months of adjustments, that it's important that we see each other in clinic. I see them 1 month post-op, and then I see them again every 2 to 3 months after that. Most patients take about 4 to 6 months of adjustments before they reach peak level of therapy. There are a few that can take as long as 9 to 12 months. That's pretty uncommon, but that can happen. If they cannot be compliant with those visits, then this may not be a good choice for them. The battery inside lasts about 5 to 7 years, so even after they reach a good level of therapy, we do have to see them back even long-term. It is compatible now with certain MRIs of the head and extremities, not of the torso as of yet. It is made of metal, so metal allergies are a contraindication, and it's not indicated for patients that are pregnant or planning to become pregnant, or in children or those over age 70. The other thing that I tell patients is, while we're going to work with you on the surgical side, we still need you to work with your primary care, with your gastroenterologist, with your entire team. There is a lot of data on enterotherapy now. We won't have time to go through all of this, but there are over 400 publications since it first came out. In the last 10 years in particular, some of the higher quality data. I'll just share with you a study that we've done locally and published a couple years ago, where we followed our patients long-term, those who have had at least 5-year follow-ups that have gastric electrical stimulation. These are pretty typical demographics, mostly in their 40s, about 60-40 female versus male. You'll see a lot of them are on opioids when they came to us, about a third of them are. And again, a pretty standard distribution of diabetic and idiopathic patients with a few post-surgical ones as well. A lot of these patients take a long time before they come to our practice, on average 4 years of symptoms before they reach us, which just kind of highlights how long these patients have been suffering for when they come to us. This is our protocol, and again, for those of interest, I'll be happy to share with this. But we have actually kind of found a sweet spot where most people seem to get ideal therapy right around 5 volts, kind of 2 or 3 seconds on, 2 or 3 seconds off. Seems to be the sweet spot for most patients. We're actually interested in a trial as to how we can get the patients there faster. So this, what we did is study, this is GCSI scores at baseline, at 1 year after, and at 5 years after, based on kind of the 3 subscales. And there's a lot of data here, but in general, preoperatively, patients had subscales around 3 to 4 at baseline. Remember, this is after 6 months of maximal medical therapy. And then at 1 year, most of the scores are closer to about 1, and this is sustained at 5 years. And again, we see reductions in medication use, we see reductions in hospitalizations, and at 5 years, about 80% of patients are still satisfied with their therapy. Obviously, we'd like to see this higher, but we're hopefully making a dent in this. One other impact, not only to the patient, is also to our healthcare system. And we also see that these patients are in the hospital a lot. They're in the hospital for a lot of days, getting IV therapy, antiemetics, and so forth. And so on the left-hand side, you can see the percent of patients, 58% of patients were in the hospital at least once in the previous year prior to presentation, and getting this down to 12 or 14%. The number of hospitalizations for those that were hospitalized on average were 3 in the past year, and again, getting this down. So again, you can see a significant reduction in the overall burden of hospital stays for patients that are in this. This is a trial that I was talking about. Now that we know kind of generally where people get good therapy, one of the things we're looking at is whether we can get them there faster. So we have a prospective multi-center double-blinded trial where we get patients advanced on the normal protocol or jump them much quicker to the standard settings. The programming is done by a study coordinator. The surgeon doesn't know the settings, the patient doesn't know the settings, or which arm that they're randomized to. And so a number of the actually other centers are in the audience today. So again, this is kind of the main parts of the surgical therapy. Just for a couple of other things to mention, obviously there's venting G-tubes and J-tubes for those that are poor surgical candidates, or those who need some hyperalimentation prior to surgery and can't do so by mouth. And then gastrectomy. And when we talk about gastrectomy, there's really 2 modalities here. One is a Roux-en-Y gastric bypass in the traditional sense. And these are for patients with gastroparesis that otherwise meet criteria for bariatric surgery per the usual measures, can actually be a very effective therapy, not only for gastroparesis, but the other comorbidities. And then there's near total gastrectomy. I have to say this is really a last-ditch resort. Most of the patients that fall in this bucket are low BMI patients, and they're very thin. This can be very difficult procedure on their body, and this involves actually removing the remnant stomach, not just stapling it aside. They do need a very short rule limb. So again, in conclusion, take-home points, failure of pyloric drainage procedures is a significant challenge. Understanding the pathophysiology is key. A systematic workup is key, starting again with a history and objective testing. Optimization, medical management, and conservative therapy should be an integral part of all these patients prior to surgeries. And again, having a lot of tools in the toolbox is very important. This has to be tailored, as Vic well said, based on the patient. So it's not a one-size hitting the right nail. I didn't even know all those types of nails, Vic, so thank you for that. And then multidisciplinary care is essential. So a lot of future directions that need to be done in this field as far as how we define failure, how we understand the predictors of failure, and other things. So with that, I think we'll conclude and appreciate questions. Thank you.
If we could have the speakers come back up. And as you're coming back up, there was a question that came in through the app for Dr. Ujicki. And the question was for Pope, do you APC the mucosa similar that you would for a TOR or fistula prior to doing the procedure?
Yeah. We don't, and we think about it. I think that there's, first of all, a randomized trial that looked at doing that for inside the stomach for the endoscopic sleeves. And I don't think it's been published, but from what I heard from the main author is that it didn't really show a difference. And the ablation did come with complications, as you can imagine, like bleeding and so forth. I think the difference between a TOR and the esophagus or inside of the stomach is that you're not getting that kind of full thickness apposition when you're doing a TOR, in particular like the stomach, you're getting serosa to serosa apposition. And so I think that I'm hoping that that's the only difference. The esophagus, of course, doesn't have serosa. But again, it's not just mucosa. Mucosa to mucosa is not going to be a durable plication. So it has to be full thickness, which it is. So we don't ablate, and that's why. And we could try it. I don't know the answer.
Felipe from Brazil. Professor Vic Benovich. You said you do not divide the short gastric vessels systematically. In your practice, how often you need to do it? And what are your strategies during your fundoplication construction to it so that it does not migrate? And finally, what's your BMI cut point to do a Nissen or a Roux-en-Y bypass in obese patients?
Right. So the first question about the short gastrics.
Yes, in your practice.
Basically, how my practice evolved over time, I started seeing more and more people with paraesophageal hernias, so that gastrosplenic ligament is already stretched out, so it becomes easier. The ones where you're going to kind of think, I might have to take the short gastrics, are people that have a very fatty gastrosplenic ligament and it's not very well stretched out. And that's the one that you kind of are going to think there might be still a bit too much tension on the Nissen. So, it turned out, I don't know the exact number of the thing, but I'm thinking it had to be like 3 out of every 4 times I'm able not to take the short gastrics, and only maybe 1 out of 4 times I would have to take the short gastrics.
In your experience, have you replicated what Watson found? Because there isn't much data other than that paper suggesting that. So in that 1 out of 4 where you have to take the short gastrics, have you noted, oh my gosh, they're so much worse?
Well, we're actually looking at that. So hopefully I'll have something for you next year.
I would venture a guess that the vast majority of foregut surgeons do not believe that and take the short gastrics with impunity.
Yep. You had other questions?
I asked.
BMI cutoff, 35. So if they're above 35, I refer them to our bariatric center. I don't do bariatric surgery. Myself, I'm too smart for that. So that's when I refer them out.
I have a quick question while we're loading up. For each of the guys, the best data is probably in achalasia, that each effort at redo never gets to the same likelihood of success for the first time. Can you each address what that is in the various areas for gastric and for fundoplication in our current understanding of things?
So your question
I
specifically.
mean, well, what is your expectation of success? There was an old study, I think it was out of Vegas, suggesting that each fundoplication didn't have the same success
No,
rate.
that
Although
is
that
definitely
new
true.
data, it's unclear to me. So I'm asking
Yeah.
for, is that true, do you think, for each of these different applications?
Well, I do think that with each subsequent fundoplication, your success rate goes down. And that's where, quite frankly, I think the magnetic sphincter augmentation comes in. Because if you have good esophageal motility, then your chances of having better success with a LINX procedure is far greater than trying to redo that fundoplication the third or fourth or fifth time.
Well, I would actually point to Samit, Samit is getting up right now, but he actually has a great paper on redos, high volume, and he showed that each subsequent fundoplication, the success rate goes down, and so does quality of life or patient satisfaction. So maybe Samit, you can comment because you wrote the paper, you had a large volume series, and he did show that. We're talking about redo fundoplications. Each subsequent redo, you're going to have worse results, correct?
More the patients get it faster and faster. The first time to redo was 5 years, the second was 3, the third was 2, and so forth. Higher intraoperative injury, lesser chance of finding vagus nerve confirming, and less antioxidant. So they're all worse and worse. So that's why Rowan, why we have to bring it out someplace to college within our that's what I think when you were saying probably after 1, at least 2 by surgeons who know what they're doing. You know, like as compared to some other person who do 3, 4 and then send them to it. You know, I just gave it from practice again, like this optional session where this is practice where you fail twice before they can do the test. We should avoid doing like my guys. Cost all the big textbooks that you need.
And Mike, what about in achalasia? What do you tell patients on the second or third time?
Yeah, absolutely. You know, the expectations are going to be lower, and you have to. I didn't come across a paper that specifically looked at that. I'm sure it's been done. I'd have to look, but I absolutely bring the expectations down. If it failed the first time, because we're not always sure. I brought up all those reasons why it fails, but sometimes you don't find a great reason why it failed. The myotomy appears to be okay. There's no reflux. Why are we, you know, not doing well? And, you know, I think with achalasia, I always warn patients, this is not just about the sphincter. You also have poor peristalsis. We just had that patient 2 weeks ago where, you know, she's wide open on endoscopy or, you know, she's got a Hill grade 3. You know, impedance planimetry confirms that. It was a high DI. But, you know, she gets food impactions actually. And well, it turns out she's got some denture issues. And so we talked about dentures and so forth, but it's not just the sphincter, it's also peristalsis. And I tell patients that at their post-op appointment after a primary procedure, I tell people, you know, great, I'm glad you're better, but just remember the rest of your life, if you eat too fast and don't chew well, you're going to have issues from the peristaltic issues.
Yeah, I can comment, and there's a lot of questions, but just in short, the literature on pylorus relaxing procedures after pylorus relaxing procedure is very meager. There's very low single-digit studies. The efficacy seems to be similar, but again, we're talking low single digits. The adverse event rate is slightly higher in the second round, with anywhere from 7 to 12% perforations and so forth. I think towards Vic's prior comment, though, kind of doing the same thing over, unless there's a very clear repeat stricture, is probably not a good idea, and trying a different modality is probably warranted.
I would actually make a comment. Actually, Michael brought this up in his talk, and I think it's worth emphasizing. The correlation between objective physiologic measurements of either gastric emptying or reflux or whatever it is frequently does not correlate well with patient perceived symptoms. And we have to be cognizant that what the patient perceives, we may not be able to fix. And this is why understanding, like you have the psychologist, and that's great, but understanding that of addressing the patient's concerns, which may not be fixable physiologically, because it's already been fixed physiologically and they still feel the symptoms, doing another operation on that in that patient's not going to help.
Things we've seen in post-Heller patients, but also post-POEM, is blown out myotomies. And certainly some are small and asymptomatic, but we have some where the G junction is wide open. And I mean, visually in endoscopy, on flip, on barium. But if you give them marshmallows or a tablet, this pouch, just everything sticks. What do you do for those?
Yeah, so obviously that is a problem. One thing that we've done to try to avoid that is we're doing shorter myotomies. We can get into this right now, and I'll stir up some controversy, but I actually think that the length of our Heller myotomies is based purely on dogma. And I think that the reason that the studies that came out with laparoscopic myotomy recommending the length is because we don't actually have a clue where the GE junction is when we do myotomies and when we do fundoplications. If you actually don't do intraoperative endoscopy, I bet you're wrong frequently as to where to put your wrap. I don't believe in slip fundoplications. We haven't seen a slip since we've been identifying the GE junction every case with an endoscope. So I believe that slips are our fault. We're doing that at the time of the operation. I also think the length of the myotomy is too long. And what we've seen with POEMs, where you actually do have a pretty good idea of where the GE junction is that we've gone shorter and shorter based on the randomized trial out of China, which we were thinking of doing actually before they trumped us. Anyway, I think one thing first is avoid it by doing a shorter myotomy. Secondly, I do think we've been trying suturing endoscopically in those cases. And I would just say it's too early to say for sure, but we've had some pretty decent outcomes in those cases.
So where do you stop the proximal extent of your Heller?
Well, we start about 5 centimeters above. We don't do 7 or 8 anymore. We used to do a 10 centimeter. Now we start about 5. So our myotomy is typically going to be no more than 5 centimeters on the esophagus and usually just a centimeter on the stomach.
Yeah, I never take the myotomy above the hiatus. That if you don't go above the hiatus, you're not going to get that blown out thing. And there's no point to going above the hiatus because all the action is GE junction and below. Failures occur inadequate distal, not inadequate proximal.
That's exactly right. Yep. I think people have a tendency to do too much, though.
It gets easy, and it's like eating potato chips.
Yeah. That's right. Yeah, but if you have a patient with like type 2 or type 3 that still actually has some motility, some pressure, you're just taking that away in the very distal part of the esophagus where they need it. So there might even be, we don't know, but that randomized trial in China showed less reflux, with a shorter myotomy, and I believe it actually.
Sergio Bardaro from Cleveland. I have to say something. I have been preparing the Pellegrini Symposium for 3 years, but this was humbling for me. It has been fantastic. So congratulations to Anna and the other organizers for all the speakers. Number one. Number two, for Dr. Awad, I have a question for you. We are still talking about gastric stimulation as the treatment for gastroparesis, but actually doesn't improve the gastric emptying, and most of the effect is on the symptoms. So I think it's not curing, but it's giving a palliation for this disease, number one. Number two, as well it happens with diabetes, and when we have to perform bariatric surgery, the timing between the diagnosis and the treatment has a big impact for the possibility of that patient to have significant improvement. We call it remission, whatever you want to call it. I don't know what it will be the translation for this disease. But do you think these patients come to the surgeon in a timely fashion? Or basically we keep those patients too long with the gastroenterologist, and when he comes, there very little you can do, or everything looks ineffective. Thank you.
Yeah, thank you. Great questions, and I'll try to be brief as I know we're a bit over time. But towards your first point first, with regard to gastric electrical stimulation, you're absolutely right. It's not been shown to improve gastric emptying. It's really focusing on kind of the sensorineural component of gastroparesis, the nausea and vomiting, which is what it's particularly indicated for, and that's really kind of the root of the treatment. You were asking also about the time to presentation, and I do think, as I discussed, we have 4 years on average from the time that they're diagnosed to the time they present to our clinic for surgical therapy, and I think that is too long. Ideally, we do want them to have dietary and behavioral modification. We do want them to have medical management. We aim for about 6 months as what we consider as a reasonable, good college try. But if at the end, and there are some patients that respond very well to that, may never come to surgery, which is wonderful. But if they do, are still refractory at that point, there's really not a lot of benefit to kind of persisting with that, I think, and we do want to offer them some additional options. Thank you.
I disagree with actually Vic said, because that's the paper of John that I don't agree with about not doing the fundoplication again. I've had a number of people who have had like 3-4 hiatal hernia repairs done, and every time the whole fundoplication fundus goes up. There is a reason the hernia is happening again rather than them failing the fundoplication. They're not venting it and the intra-abdominal pressure, rather than venting from the stomach, they're venting it through the diaphragm. So I think we should change it especially from a nascent to a toupee or something. So maybe they will have some venting rather than just blowing it back up. So that's one thing that I disagree with, that quoted paper that you have said. Probably 3 people now who have had 4 or 5 hiatal hernia repairs done, the fundoplication not touched, and they've had 1 to 2 year follow-ups, and they're okay for now. So,
well, I think it's a win that you only disagree with me on one thing. So, I was expecting more than that.
Hi, Sven Erickson, Allegheny Health Network, Pittsburgh. I have a question for Dr. Awad. You mentioned that a key piece of evidence in workup for redo pyloric drainage or gastric stimulators, getting that 4-hour gastric emptying study. However, not too infrequently, we've had patients who are so symptomatic they're unable to complete the study. So I was wondering what your approach was when you can't get that core bit of information.
Yeah, that's a great question, and we do see some patients who are in that boat as well. They can't even tolerate the smell of the the eggs or the toast. They extreme vomiting, almost completely NPO. We do our best to try to have them do the study with very aggressive antiemetics beforehand. You do want to try to have it done to see if you can at least get a partial test. And it's, again, sadly, for better or worse, a big part of insurance approval for a lot of these therapies, the gastric electrical stimulation, GPOM, and others. And without it, it can be an uphill battle just to get insurance to approve it. We actually will do, while best practice to hold prokinetics, if they need it to get the study done, we will have them do that and just kind of note that they were on motegrity or domperidone or any of their prokinetics. And it's actually, telling if they still have delayed emptying while they're on those. That even kind of further adds evidence that maybe they're a better candidate for surgery. But yeah, there's some patients that, despite our best efforts, we can't get it done. I'll just do my best to document that in the note. And generally, we can still kind of get them through to a surgical procedure. Yeah.
Great talks by all 3 of you. A comment for Dr. Ujicki. Cleveland Clinic just presented their series of poem after prior Heller at the American Thoracic meeting. And much like you suggest, patients all improved, but their outcome was not quite as good as the primary Heller, for sure. So that answers some of that question. A couple of quick questions for Dr. Awad. We have a multidisciplinary gastroparesis group of which we're part of. RGIs make a differentiation between pain-predominant gastroparesis versus nausea-vomiting predominant gastroparesis, and they prefer us not to do anything with the pain ones. That's the first question. Second question is we have a hard time getting electrical stimulation approved for non-diabetic patients in the Northwest. That's one of the second question. How do you do that? Third question is combined modality therapy. So why not electrical stimulation plus drainage procedure? Would that not have, that seems to have some legs in some of the papers, but is that sort of your experience as well? So 3 questions.
Thanks, Brian. And let me see if I can remember each of the 3. The first one, pain predominant, yes.
Do you guys make a differentiation?
Yeah, so there is. And in fact, if you look at the 2021 AGA guidelines on this, they actually have kind of a 2-branch algorithm that is nausea-vomiting predominant, which they indicate gastric electrical stimulation and other surgical therapies for, and pain predominant, in which they actually recommend no surgical therapies for, and just cognitive behavioral therapy and other things. And similarly, Intera is indicated for nausea and vomiting for gastroparetic. So in our practice as well, we find that indeed more of the symptom improvement is in that bucket. We don't make any kind of promises with regard to improving abdominal pain or those things, so similar practice. The second was, yeah. I will say it's gotten a lot better over the last probably 5 to 7 years, regardless of the subtype, diabetic or idiopathic or post-surgical. And I dare say that that's probably because of that 6 months of monitored medical management. We documented very carefully all of the prokinetics, antiemetics, dietary, behavioral, so that we can truly demonstrate that they are refractory. But I will say, knock on wood, right now, we almost universally get those approved. I will just kind of note as a public service announcement, there is a new AGA guideline draft that's out for public discussion right now. I'd encourage everybody to take a look at that and comment on that. There's some kind of interesting comments in that draft that may affect our treatment of gastroparetics, and would encourage everybody to take a look and comment on that. Tuesday morning, there's going to be an open panel about those draft guidelines that may change some of that and affect insurance approval. So, but for now, knock on wood, we're getting them approved almost universally. And then the third, also, great question. In short, I think the jury's still out. I think there's some really interesting and promising studies at both combo gastric electrical stimulation and pyloroplasty, or GES and GPOEM, either in concurrently or subsequent to each other. And I think we'll see. The jury's still out on that, but there is some rationale I can see to doing those at the same time. I think there's a theoretical risk of exposing kind of the foreign body to enteric contents for a lap pyloroplasty that may be avoided during a GPOEM, would be my only kind of caveat in that, but that may be a theoretical rather than real concern.
Actually, we're presenting a paper on that. It does increase the infection risk. Yeah, so was that presented already, Tuesday? So, yeah.
Last question. We're over, but everyone's so excited. So.
My question is, like a young lady who has gastroparesis already had a gastric stimulator device, and if she got pregnant, you said there is no safety data. So do you turn off the stimulator, or do you keep the stimulator on?
Yeah, that's a great question and a difficult situation. And so by FDA guidelines, we are obligated to tell that patient that we do need to turn the therapy off during the pregnancy because it hasn't been tested. And that's hard because those patients, on top of their baseline nausea and vomiting, can have a hyperemesis of pregnancy that can make their symptoms even worse. And if they've already been feeling good with the stimulator, to turn it off can be a very difficult decision. Obviously, it's their decision. Some will agree to turn it off, some don't. And they will go through their pregnancy with the stimulator on. There's actually, we just had a kind of a user group meeting of other Intera implant providers to actually take our kind of pool of patients in that cohort to try to see if there's any evidence if there's a teratogenic effect. Anecdotally, it doesn't appear to be, at least in the short term, but by the book, we're obligated to tell the patients we need to turn that off. And then we obviously turn it back on when they've come to come to term.
All right, well, thanks, everyone. This was a great session. Appreciate everyone coming out. And if you want to talk to everyone afterwards, they'll be around.